Welcome to the video for chapter 13.4. So in today's lecture, we're going to talk about concepts of antimicrobial therapy. So we're going to talk about what we term as antimicrobial therapy and some of the verbiage, some of the vocabulary that goes along with it. Let's talk about the section objectives for this lecture. You need to be able to explain the concept of selective toxicity and its importance for clinically useful antibiotics. You need to be able to explain what is meant by a spectrum of activity and discuss its clinical importance. You need to be able to discuss the effectiveness of an antibiotic. So how is it tested? And how does it differ from minimum inhibitory concentration, or MIC, from minimal bactericidal concentration, MBC. And then also you need to be able to describe and calculate a chemotherapeutic index. So let's start this with a case history. Now, this is all about 3-year-old Molly, who was brought to the emergency department crying. She has a stiff neck and a high fever. Okay, remember, we've talked about this case study before, right? So Molly, because of the stiff neck and the high fever, one of the first things they're going to do is they're going to do a spinal tap, and they're going to pull a sample of her cerebral spinal fluid. Now, when they do that, we get the classic example of infection, right? Instead of having clear like a normal CSF, she's going to have all these white blood cells in her CSF, which means she has an infection. Okay, so they're going to take a little bit of her cerebral spinal fluid, and they're going to do a gram stain, and they're going to plate it onto some agar to grow. Okay, her gram stain is going to reveal that she has gram-negative rods. So between the cloudy CSF and the gram-negative rods, Molly's physician's going to assume that it's meningitis. So they're going to immediately prescribe intravenous ampicillin to take care of it. Okay, so within hours of being given the antibiotic, Molly's going to begin to improve. Okay, her symptoms are going to lessen. She's not going to be feeling as much pain. She's going to stop crying. And she improves so much that within 2 days, she's going to be released from the hospital. Now, as she's being released, the report comes from the clinical microbiology laboratory that confirms that the microbe causing her infection is Haemophilus influenzae type B, which is a known cause of meningitis. Now, one of the other tests that they ran is a antibiotic susceptibility test. Okay, so what antibiotics is this strain of bacteria going to respond to? Well, they do find that her strain is susceptible to ampicillin, so her doctor made a good choice choosing that antibiotic that affects gram negatives. Now, if we look here at the picture here, what we see is on the peripheries, we see bacterial growth. Okay, so what we're going to do is we're going to test the antibiotic and how well it works against this microbe. So we're going to plate a lawn, okay, get a lot of growth of the microbe, and then we're going to put something here with antibiotic on it that's going to allow us to see how the antibiotic works on that microbe. So as we see here, the higher the concentration, so up towards here, okay, we can see a really large, what we call a zone of inhibition. So the antibiotic is preventing growth in this area. Okay, so the bigger the area with no growth, the larger the inhibition. Okay, and usually the more concentrated the antibiotic in that area. So as we follow this down, 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 okay, we see that the zone of inhibition is decreasing with the concentration of our antibiotic until finally we get to a point where it's no longer working. Okay, so it's not concentrated enough to actually affect the bacteria at that point. So one of the things that we need to talk about is the amount of vocabulary and terms that we're going to learn in this section. Okay, some of them we kind of have been talking about, but we just need to put a name with a scenario. Okay, so we are going to talk about what we define as an antimicrobial. Okay, these are going to be chemicals that are synthesized by one microbe that selectively kill another microbe. So if we think back to how we discovered penicillin, one of the things that happened is that mold made an antibiotic that killed all the bacteria around it, so that mold could have all the resources available to it. Okay, the penicillin, that chemical that it made, that's an antimicrobial. Now, antimicrobials can be natural, like what the mold was making, and they can be chemically synthesized in a lab. So we have an umbrella term that doesn't separate natural versus synthetically made antibiotics, and that is chemotherapeutic agents. Okay, so this is just an umbrella term for all antimicrobials. Now, we've been talking a lot about how antibiotics are going to target things that are specific to bacteria, but not eukaryotic cells. We have a term about this, we just haven't talked about it so far. Okay, the term is selectively toxic. Okay, that means that the antibiotics are going to only affect the bacteria without causing any harm to the eukaryotic organisms. Okay, because they're selectively toxic and don't cause any bad side effects, they earned the name the magic bullet soon after penicillin was discovered and offered globally and was easily accessible. Okay, so it's going to kill the bacteria without killing the patient. Now, we have this scenario here. So this was taken shortly after penicillin was released for use in hospitals. So we have this little girl that has a pretty terrible wound and is infected, right? Now, before penicillin was available, this little girl was a goner. Like, this was a death sentence. There was no coming back from this. Okay, so she was one of the first ones that penicillin was administered to. Okay, so this is what she looks like on day 4. Can you imagine what she looked like on day 1? This is day 9. Okay, so she still has some necrosis of the tissue. Okay, but you can see the infection receding. We don't have all that black tissue anymore. Well, several days later, she's fully recovered, right? It's almost as if she didn't have an infection at all. This was magic in the term of a lot of people in that time. Okay, something that was a death sentence was now survivable. Now, this had some pretty bad consequences, right? Because it was considered the magic bullet, it was prescribed for everything, and it did work on quite a lot of things. In fact, when penicillin was first administered, it had what was called a broad spectrum of activity. Okay, so it could affect a lot of different microorganisms. Okay, so what was happening here is you take penicillin and it killed most gram-negatives at a time. Okay, so the spectrum of activity is the range of organisms an antibiotic works on. Okay, if it's a broad range, it works on more. If it's a narrow range, it works on less. So let's talk about some vocabulary. These are going to be important for Lab 7. Okay, so this next test that we're going to talk about is what we call in vitro. So in vitro tests literally mean tests in glass. These are test tube tests. Okay, so they're going to be the way to measure the effectiveness of antibiotic on a microbe. Okay, so we have what is called the MIC, or minimal inhibitory concentration. Sometimes you hear this referred to as MIC. Not as much anymore, but sometimes. Okay, so the minimal inhibitory concentration is how little of the antibiotic do you need to inhibit growth, to stop growth. Okay, so we have our test tubes here. Okay, each of them has the microbe in it that we're testing against. So these numbers up here are the concentration of the antibiotic. Now, in this case, this is tetracycline that's been serially diluted, just like we did in the lab, trying to figure out the number of bacteria in our sample. Okay, so in this one, we see clear growth. In this one, we see clear growth. Okay, no growth, no growth. And then finally, we get growth again. We become cloudy. Okay, so this test tube, this 1 microgram per milliliter, is what we call the minimum inhibitory concentration, because this is the last tube where we didn't get any growth that we could see. Now, this is called the minimal inhibitory concentration because it's just stopping growth. It doesn't necessarily kill the bacteria. Now, minimal bactericidal concentration, MBC, is the measure of how many cells you killed or how well it kills the bacteria. Okay, so MBC is how little of the antibiotic you need to kill the bacteria. Now, with MIC, this is fine. This tells us the effectiveness. This is all we need to do. With MBC, we need to do further testing. Okay, so what they're going to do is, if this was an MBC test, they're actually going to take this sample and they're going to plate it. Okay, and when they do that, they're going to look for any growth that happens, because any growth that happens means that not as many bacterial cells were killed as we thought. Okay, so the less growth on the plate, the better it is at killing the microbe. Okay, you need to know MIC and MBC. Know what these mean, okay, be able to explain them. This will be something you're tested on. Now, one of the ways that we find minimum inhibitory concentration is we do a bunch of tests. We call these tests assays. Now, we're going to do these in Lab 7. So this is kind of a good slide to pay attention to. So we call them disk diffusion assays or Kirby-Bauer assays or Kirby-Bauer tests. So what we're going to do is we're going to use little filter paper discs that have been soaked in antibiotics. Okay, they're dried out, they're not wet. So what they're going to do is, once we put them on a plate with growth, they're going to either affect or not affect the microbe that we're using them on. Okay, so what we're going to look for is these zones of inhibition, just like in that example problem. How big is the cleared area around that antibiotic? The larger the zone of inhibition, the better that antibiotic works. Okay, the larger the zone, the less of that antibiotic is needed to actually treat that microbe and get rid of it. Now, we have a bunch of different abbreviations here. So ox is oxacillin, P is penicillin. Now you can see for this microbe, penicillin does not work at all. This is one of our penicillin resistant ones. Okay, we have E is let me give you a second, guys. This one takes me a minute to say. Erythromycin. Okay, we have VA, which is vancomycin, and I really don't know the other ones off the top of my head. One of them is clindamycin, but don't ask me which one it is. Okay, so we're going to have both of these plates. These are going to be different microbes. Okay, so we can see, based on what we're seeing here with the zones of inhibition, between the two different microbes, we get two different effects with these antibiotic discs. So in this test, almost all of these affected the microbe. So the microbe is susceptible to antibiotics. There's very little resistance here. Now, with this guy, well, we have erythromycin, we have oxacillin and penicillin, which aren't going to actually be very effective against it. Okay, so this microbe is resistant or partially resistant to some of these antibiotics. It doesn't respond as well as this one. Now, one of the reasons why we test multiple antibiotic discs is sometimes the patient's allergic to certain antibiotics. So with this one, erythromycin works really great. Okay, it's not as good as like penicillin, but maybe our patient is allergic to penicillin, so we're gonna prescribe something like erythromycin or the SAM over something like Vanco, okay, because it has a larger zone of inhibition. Okay, so with zones of inhibition, we have to look at both what the antibiotic does and its concentration, because concentration is going to cause differences in the zone of inhibition. The more concentrated something is, the larger the zone is going to be. Okay, so this is what we call a susceptibility results chart. So this is going to tell us the ranges for susceptibility for Staphylococcus aureus. Okay, so we have a bunch of different antibiotics. We have ampicillin, we have erythromycin, we have gentamicin, we have streptomycin, we have tetracycline, and this one I can never say right. So we have that one. Okay, so this is the quantity in the disc, so this is the concentration. So if you see this, tetracycline and this one are almost 3 times or twice as concentrated as the others. Okay, you have to take this into account when you're doing comparisons, okay, because the more concentrated it is, the bigger the zone of inhibition. Okay, so if I run a test with ampicillin and I get a zone of inhibition that's around 10.5, well, if we go and look at these values here, so we have values that tell us it's resistant, it's intermediate, so it's partially resistant, or susceptible, meaning that the antibiotic is going to kill it. So if we have a value of 10.5 for the zone of inhibition, well, that's less than 12. That means that that organism is resistant to ampicillin. Now, if we had a number like 16, well, that's greater than 13, so that makes it susceptible. But if we look here at tetracycline, 16 is going to be intermediate. So it's not resistant, but it's not fully susceptible either. Okay, these are good charts to know because you are going to be able, you're going to be reading charts like this in lab 7. Okay, we're going to get our rulers out and measure your zones of inhibition with the ruler. So this is always in millimeters. Okay. So we have our MIC tests, we have our zones of inhibition. What does this really mean in terms of how effective an antibiotic is in the hospital, right? Is it clinically useful? Okay, so one of the things we have to do when we are administering antibiotics, we have to be able to keep the drug concentration in the patient's body above this minimum inhibitory concentration, or it's not going to affect the microbe. Okay, so this is actually something that healthy people do. This is how we get curves like this. So what's going to happen is that they're going to be given the antibiotic, and every half an hour, they're going to have their blood tested to see how much of the antibiotic is in their system. Okay, so we can see at first it takes a minute, but it reaches this peak that this means that you have as much antibiotic in your system as you can have with your current dosage. And as we see, as time progresses, our slope is going to decline until we have very little in our blood serum. Okay, so what we're going to do is we're going to take this curve from our tests and we're going to plot it against the minimum inhibitory concentration. Okay, so if we see where these two curves interact, okay, it's here around 7-8 hours. Okay, what this tells us is that in order to keep the drug in the system enough to suppress or kill the infection, we have to administer new doses within 7 or 8 hours of the first one. Okay, this is how we decide how often you take medication. Okay, some antibiotics you have to take 2 or 3 a day at very set intervals of time. Sometimes it's once a day, sometimes it's 2 tablets once a day. It all depends on the curves for that antibiotic. Okay, well, one of the reasons why the antibiotic, the amount decreases in your system, is it has a half-life, or what we call a bioavailability in pharmacy. Okay, so how much of that drug is available to be used for therapeutic reasons? Okay, so it also refers to how quickly your kidney and your liver can actually break down that antibiotic and get it flushed out of your system. Okay, so for this one, it's fairly quick. So this is going to tell us that we're going to need to administer a new dose every 6-7 hours so we don't go past this minimal inhibitory concentration. Okay, we want to keep it above this line at all times. Okay, so this is going to not only affect how many times you take your antibiotics, but it's going to affect the dosage as well. Now, with that curve and with those tests, there comes some other vocabulary words. You need to know these. You will be tested on this. Okay, so we have 2 terms, well, 3 terms, and I want you to know them. The first one is the therapeutic dose. Okay, this is the minimum dose per kilogram of body weight of the patient that's going to stop or inhibit growth. Okay, we have what is called the toxic dose. This is the maximum dose tolerated by the patient before bad things happen. Okay, it's not going to particularly kill the patient, but it's going to make them really sick once you hit that toxic dose. Okay, so we're going to take a ratio of the toxic dose to the therapeutic dose, so toxic divided by therapeutic, and this is going to give us a number, and it's going to be called the chemotherapeutic index. This number tells us how safe the drug is for that patient. Okay, the one thing I want you to remember, hence it's underlined, the higher the chemotherapeutic index, the safer the drug is. So let's take this knowledge and let's apply it to a problem. This is a good one to know. Hint, hint, hint. Okay, so we have drug A. It has a toxic dose of 12 grams per kilogram of body weight and a therapeutic dose of 6 grams per kilogram of body weight. Drug B has a toxic dose of 6 grams per kilogram of body weight and a therapeutic dose of 2 grams per kilogram of body weight. Which of the following is true? A. Drug A is the safer drug. B. Drug B is the safer drug. C. Drug A has a higher chemotherapeutic index. And D. Drug B has a lower chemotherapeutic index. Okay, so take a minute, pause the video, use the previous slide, and see if you can figure out what the answer is. I'll give you a second. Okay, so what we need to look at is these numbers. We need to take the ratios. Well, our chemotherapeutic index means that we're taking the ratio of the toxic dose over the therapeutic dose. So for drug A, that's 12 over 6, so that's going to give us 2. And for drug B, this is going to be 6 over 2, so that's going to give us 3. Okay, well, drug B has the higher chemotherapeutic index, which means that D is wrong and A is wrong. Well, if A is wrong, C is wrong. So the answer is B. Drug B is the safer drug because it has the higher chemotherapeutic index. Now it's only 3 to 2, but it's still bigger. Okay, so the answer is B. So this is a little bit of math. You will have to do this on the next exam. Okay, so this is the equation, chemotherapeutic index equals toxic dose over therapeutic dose. So this is the math that led to the answer on the previous slide. Good one to know. A lot of times when we're trying to determine if an antibiotic is clinically useful, is we need to look at it, how it responds to other antibiotics. So one of the current methods of treatment is to make antibiotic cocktails. So we're going to prescribe 2 or more antibiotics in a mixture to hopefully stop or slow down the spread of antibiotic resistance. Okay, so the more antibiotics you're going to use, the less likely your bacteria are going to become resistant to any of them. Okay, when we're talking about how antibiotics interact with each other, this is part of what we call pharmacology. Okay, in fact, a lot of this chapter is pharmacology. So if you decide to go into something like nursing or go into any healthcare field, you're going to take a pharmacology class. So this is some good things to know. So we have 2 terms that we use in pharmacology with how drugs interact with each other. One is synergistic and the other is antagonistic. Okay, so this is going to tell us what those drug cocktails are doing. Now, synergistic means that the drugs combined make both of them better. So it increases their effectiveness. Okay, this means it's an additive effect. So if we have good old vancomycin, which is a beta-lactam, and we combine it with an aminoglycoside, it makes both of these more effective and work better. Okay, we have the opposite. We have antagonistic drugs. This is going to do the opposite of synergistic. It's going to make them interfere with each other and make them less effective, or make them not work at all. Okay, so an example of this is penicillin and a class of drugs called macrolides. Okay, so you need to know both of these terms. You will be tested on both of them. Okay, so that is chapter 13.4. We've talked about selective toxicity. So something we've been referring to since the first of the class, we now have a name for it. We've talked about minimum inhibitory concentrations. We've talked about Kirby-Bauer tests. You guys should be ready to do lab 7 now that this lecture is over. So we'll see you in the video for section 13.5.